And these are my disclosures, but my most important disclosure is that I don't perform left atrial appendage closure procedures, but I do try to reduce the risk of stroke in my patients with AF. Tom asked me to give this talk, and I said, but I don't do this procedure. But I thought about it some more, and he's right. That's my objective when I see a patient with atrial fibrillation. The first objective I have is to reduce their risk of stroke, and that's the greatest evidence we have in clinical medicine as the most important objective in a patient that we see with atrial fibrillation. And as my two colleagues elegantly went over with you, it's really a risk-benefit decision. So let me go over with you what I view as the place of left atrial appendage occlusion in these group of patients with atrial fibrillation. So it's really remains a major unmet need in AF stroke prevention, despite what we've heard about from Osama and Tom about systemic oral anticoagulation. There's still a very large number of patients who remained at high risk of stroke, who we're not serving very well. There are about 2.5 million people in the US with AF who remain at high risk of stroke, CHEDS 2 greater than 2, and 40% of these patients don't take an oral anticoagulant, be it warfarin or a NOAC. If you look at the NOAC trials, about 2 to 4% rate of major bleeding. Tom gave it a number of 3%, which is the right number to remember annually. And about 30% of patients in the trial stopped the NOAC within 2 years. And the major unmet need is in the elderly population. They suffer the burden of strokes in these patients. We know that patients over age 80, for example, 30% or more of strokes are attributable to atrial fibrillation, and the 70 to 79 age group, about 15 to 20% of strokes in these patients are attributable to atrial fibrillation. So this really is a preventable cause of stroke. And we also know that strokes in patients with atrial fibrillation are not typically very minor strokes. They often are very large strokes. They often involve a very large portion of the brain. These are often hemorrhagic strokes, and because they're hemorrhagic strokes, the risk of dying with these strokes is very, very high compared to patients who have strokes in the absence of atrial fibrillation. So it's a major morbidity, major mortality issue. And if we look at the effects that the NOACs have had on clinical practice, by and large, what it's done, as Osama has told you, is provide an alternative to warfarin. It has not really had a major impact on this unmet need, which is about 40% of patients who are at high risk of stroke with atrial fibrillation still are not receiving oral anticoagulation therapy. And these are older data, but these are data that have been more recently updated from the NCDR registry, showing that about 40% of patients in the US are not receiving an oral anticoagulant, despite the fact that they're high-risk stroke. And you know, it's been beaten into our brains over the last decade that we're not meeting the guidelines, that we're not providing appropriate guideline-based care in terms of preventing strokes in our patients with atrial fibrillation. And I don't believe that it's because we're poor in our management. This is really the heart of the problem that we're faced with, is that the problem is that patients who are at high risk of stroke are also at high risk of bleeding. And if you look at the risk benefit ratio in these patients, it doesn't always favor anticoagulation. And the problem is that many of the risk factors that are in the CHADS-VASc scoring system, 3 in particular, hypertension, prior stroke, and age, are the same risk factors that are in the bleeding risk scoring systems. For example, the HAS-BLED scoring system also includes these risk factors. So if you're at high risk of stroke, for example, a CHADS-VASc score of 4 or 5, you're at high risk of bleeding. And if you look at the 10-year risk of bleeding in these patients, it's over 60% risk of bleeding on an oral anticoagulant in these patients. And this is really the problem that we're facing as clinicians. And this has changed the paradigm thinking. Now it's been more than a decade to switch from a systemic therapy with the adverse effects of bleeding to more of a local therapy. And the device that I'm going to be talking about is the Watchman device, because this is the only one that's currently FDA approved in the United States. But there are a whole host of other devices that can provide local therapy to occlude the left atrial appendage and reduce the risk of stroke potentially. So we're talking about local therapy versus systemic therapy. And the mechanistic basis of this comes back now more than 10 or 20 years based on both TEE data and autopsy data showing that in non-rheumatic atrial fibrillation, most of the thrombi, most of the strokes come from the left atrial appendage. This is not always true in rheumatic valvular atrial fibrillation. Many of those thrombi actually occur in the left atrium itself, but in non-valvular atrial fibrillation, which is the vast majority of patients with AF, these thrombi come from the left atrial appendage, over 90%. And that led to the development of this local therapy, which you can see here, including the left atrial appendage. The Watchmanis, which I'm going to focus on, involved over 3,000 patients, 2 major clinical trials, 2 randomized trials, PROTECT AF and PREVAIL, that we have available here. And I'm going to review those data with you and talk about briefly what I see is the shortcomings and really what the unanswered questions are. So if you look at the data in these trials, the PROTECT and PREVAIL patients were at high risk of stroke. They had a mean CHADS VAS score over 3 to 4, which equates to about a 3 to 5% risk of stroke per year. You can see in the individual trials what the CHADS VAS score is, but you can see by and large these were all high-risk patients. And at the same time, as I alluded to you, based on the scoring systems, you would predict these patients would be at moderate to high risk of stroke. And in fact, most of these patients either had a HAS-BLOOD score of 2 or 3, 3 being the high-risk group. These are the overall data here, a meta-analysis from Vivek Reddy looking at PROTECT AF and PREVAIL, which were the 2 randomized trials comparing Warfarin, which was the standard when this technology was initiated, to the Watchman device, left atrial appendage occlusion. And you can see the overall efficacy shown on top for prevention of stroke is non-inferior, comparable. So it's about the same. You also look at other endpoints, which is a critical piece, I think. If you look at cardiovascular death, shown in the middle here, there's a 50% reduction in cardiovascular death. If you tease this out a bit more, if you look at all strokes, although there's no difference, there was a clear advantage in terms of prevention of hemorrhagic stroke. And this is what you would predict, prevention of hemorrhagic stroke. Why? Because you're avoiding the systemic effects of oral anticoagulation, and therefore you're reducing the hemorrhagic stroke rate. The ischemic strokes overall were comparable. There wasn't a statistically significant difference, but there was a trend to a higher risk of ischemic stroke, which with the Watchman device. Disabling strokes were significantly lower with the Watchman device, and this would be predictable as well, as because the disabling strokes are typically those strokes that are associated with significant intracerebral hemorrhage. And these are strokes that often result in increase in mortality even if you survive. Going back to the ischemic stroke issue, actually it turned out that initially when this technology came out, as you would expect, there was a significant learning curve. And once the learning curve was obviated by those who had began to have increased experience with this procedure, the initial procedure-related strokes were decreased, and overall, there were comparable effects on ischemic strokes. And what we've seen is that as this technology has gained acceptance both in the US and Europe, the procedural experience has improved and the procedural complication rates have declined. So we would expect, although we don't have data, that the ischemic strokes would be either comparable to warfarin or superior to warfarin with a reduction in the procedural events. For those who are not familiar with this technology, it does require short-term anticoagulation with warfarin, and that's because it takes about 45 days, 6 weeks for the device to endothelialize. You can see here in a canine model on the left at 30 days, you can still see the Watchman device in the left atrial appendage. On the right, by 45 days, it's completely endothelialized and covered over without a communication with the left atrium. Therefore, patients are required to take warfarin at this point for at least 6 weeks post-implant. The typical anticoagulation regimen is warfarin and aspirin for 6 weeks, 6 weeks to 6 months. You can switch to a dual antiplatelet therapy with clopidogrel and aspirin, and after 6 months, patients just remain on warfarin. So by 6 months in the clinical trials, more than 90% of patients were totally off warfarin. And that resulted in a marked decrease in the overall risk of major bleeding with the Watchman device versus warfarin. There was a 72% risk by 6 months decrease in the risk of major bleeding after the procedure, because these patients can safely get off warfarin, and you would expect a decrease in major bleeding. So this is what we have at this point, the overall summary of the clinical data with warfarin. It's comparable to overall stroke prevention. It's, at this point, based on the data, inferior for ischemic stroke prevention, but these appear to be in part related to procedure-related strokes, air emboli, clots coming off during the procedure, and this is clearly decreased with operator experience. Importantly, it's superior for prevention of hemorrhagic stroke, and because of this, it's superior in terms of reducing disabling and fatal strokes, again, versus warfarin, and it's superior for reducing cardiovascular mortality. It's quite impressive, and I would emphasize this point, the reduction in cardiovascular mortality. I don't know many therapies which is associated with a 50% reduction in cardiovascular mortality in clinical medicine. That's a quite dramatic effect that even the naysayers for this therapy can't dismiss lightly. And overall, it reduces the bleeding risk compared to long-term systemic anticoagulation. About 15 months ago, this resulted in CMS national coverage for this, February 8th, 2016. CMS agreed to cover the Watchman device as the only FDA-approved device for patients with CHA2DS2-VASc scores greater than 2 or 3, unable to take long-term oral anticoagulation, and viewed this as a second-line therapy after oral anticoagulation. It involves a shared decision-making interaction with a non-interventional physician, that is the person who's not necessarily doing the procedure, as well as with the patient. Patients have to be in a registry, and the operator has to be somebody who has experience with doing transeptal procedure, either an interventional cardiologist, an electrophysiologist, or cardiovascular surgeon. And this was the FDA labeling, and what I highlight here is this is a clinical paradox. The FDA labeling was that patients who could only get this device who were suitable for warfarin. But the clinical paradox is the greatest unmet need for stroke prevention with left atrial appendage closure is in those who cannot tolerate oral anticoagulation. Yet the randomized clinical trials of left atrial appendage closure have enrolled patients who are eligible for oral anticoagulation. So we have a therapy which we want to use in place of oral anticoagulation, but the data is based on patients who could receive oral anticoagulation. And this really is the unanswered question in a sense, and why the case I don't think is necessarily closed in terms of this type of therapy. And the question becomes, what's the alternative? In these patients who are not suitable for warfarin or for a NOAC, for example, because of a high long-term bleeding risk, what can we do? Well, what we typically do is give them nothing, placebo, no therapy, or we give them dual antiplatelet therapy oftentimes is what we do in clinical practice. We either give them aspirin or aspirin and clopidogrel with the hope that will reduce their stroke risk without increasing the bleeding risk and not increasing mortality. This is a recent meta-analysis that I think sheds some light on this issue. So these are patients who were in the randomized trials looking at left atrial appendage closure compared to the efficacy of no therapy placebo mostly in the warfarin trials versus dual antiplatelet therapy, mostly coming from what was known as the active trial. And you can see here the left atrial appendage closure, at least based on meta-analysis, is associated with a higher survival here. You can see here the survival versus no therapy placebo is approaching 60%. Improvement in survival versus dual antiplatelet therapy, shown on the left, is about a 40% improvement in survival. Versus stroke and systemic embolism. There's also a marked benefit, about an 80% reduction based on meta-analysis data in the risk of stroke with a similar bleeding outcome. You can see the bleeding outcomes on the right. Major bleeding, intracranial hemorrhage, and GI bleeding. So in terms of comparison to the alternatives based on the data we have available, the left atrial appendage closure seems to be superior. We now do have more clinical data available. In Europe primarily, this device is only indicated in patients who are not suitable for oral anticoagulation. At least we have registry data. This was just published in Heart Rhythm and presented at HRS data showing here the EWOLUTION Registry, which showed that over 1,000 patients, 73% of these patients were unsuitable for oral anticoagulation. 85% received antiplatelet therapy, and you can see overall a very low risk of stroke, 1.1% risk of stroke in these patients, so much lower than the predicted risk of stroke. In a group of patients with a CHA2DS2-VASc score of 4.5, you would expect them to have at least a 5 to 6% per year risk of stroke. You can see overall the ischemic stroke rate is 1.1%. There's begun a randomized clinical trial comparing Watchman to use either single antiplatelet therapy, aspirin, or no therapy. You can see here aspirin or clopidogrel are the options, and these are going to be randomized data, the ASAP-2 trial, that we probably won't hear about for another 3 or 4 years. The other alternative is obviously the NOACs. Should we use the NOACs in place of left atrial appendage occlusion? Osama reviewed these data. We know that the NOACs provide an advantage in terms of major bleeding. Most importantly, as you can see here, they provide an advantage in terms of reduction in intracranial hemorrhage, which with a slight increased risk of GI bleeding. If you look at the Averroes data, in patients unsuitable for warfarin, which is the population we're talking about for left atrial appendage occlusion, there was a marked advantage of apixaban over aspirin. You can see major bleeding was not increased, with a 60% reduction in the overall stroke risk in these patients. So the NOACs look awfully good, and as Osama said, the major advantage of these is a reduction in intracranial hemorrhage. The question becomes, are the NOACs going to be an alternative to left atrial appendage occlusion, or better said, should we use the left atrial appendage in place of the NOACs? And I think the answer is unknown at this point. Again, if you go to this meta-analysis I highlighted before, it looks like there's not going to be a major advantage, at least based on the data that we have available at this point. Indirect comparisons show that there's similar mortality stroke rate with a lower rate of GI bleeding, and because the intracranial hemorrhage rates are about the same. And the problem with these data that I highlight here is that the median follow-up was only 21 months, and if you look at the NOAC trials, by 2 years, 30% of patients stopped their NOAC. So the really question becomes long-term, what is going to be the options for these patients? At this point, we don't have any data to say whether the NOACs are superior to left atrial appendage occlusion. There is a trial begun. It's a small trial, and what I'm going to say here is this is, I think, what the data speak to at this point. Left atrial appendage closure has a major advantage compared with warfarin, with a lower risk of bleeding and a similar efficacy for stroke prevention. Left atrial appendage closure with Watchman is a reasonable option to recommend to patients at high risk of stroke, considered poor long-term systemic oral anticoagulant candidates due to a perceived high risk of bleeding. But there's still many questions remain. What about patients who can't even take short-term anticoagulation, 6 weeks of warfarin? The ASAP-2 trial is looking at that, and I think based on the meta-analysis I showed you, it's likely this will be another option in the future versus the NOACs. It's really unknown at this point. What about patients who have stroke despite an oral anticoagulation and a therapeutic INR? There still are these patients out there. What about patient preference? What about patients who want to go rock climbing or skiing or whatnot? And I think these are going to be the options in the future. And it's likely that this technology is going to improve and is going to expand the number of patients that we have available. Thank you for your attention.